Hello and welcome. I'm your host, Neil Howard. Thank you so much for joining us for another segment of Health Professional Radio. September is Prostate Cancer Awareness Month. It's an important time to highlight the most common non-skin cancer diagnosed in men. In their lifetime, about 1 in 8 men or so will be diagnosed with prostate cancer, which is also the second leading cause of cancer death in men. Joining us here from City of Hope is Dr. Tanya Dorff to discuss some new targets in prostate cancer beyond prostate-specific membrane antigen, or PSMA, the use of CAR T-cell therapy in patients with prostate cancer, and the different combination of drugs that have shown some efficacy. Welcome to Health Professional Radio, Dr. Tanya Dorff. Thank you for joining us.
Thanks for having me.
Give us a bit of your professional background. Let us in on who you are and your role at City of Hope.
Sure. I'm a medical oncologist, so I treat cancer patients with treatments for the whole body, things like hormone therapy, immunotherapy, chemotherapy. And I work, obviously, in a team with surgeons and radiation doctors. I focus on prostate cancer, and that's where my research interest is. So I came to City of Hope to do immunotherapy research in particular. And at City of Hope, I head the Genitourinary Disease Program.
Now, I mentioned PSMA. What is PSMA? It seems to be the new buzzword in prostate cancer treatment. Tell us a bit about it.
PSMA is a protein that has been successfully targeted as a diagnostic and therapeutic. So it stands for prostate-specific membrane antigen, but truthfully, it's not completely prostate-specific. So for our imaging, we use PSMA PET scans, which can find little bits of prostate cancer long before we could see it on a conventional imaging like a CAT scan or a bone scan. But you'll also see, for instance, the salivary glands light up because they express PSMA. So not completely specific, but it is very highly concentrated in prostate cancer, especially in advanced stages. And so people have manipulated, for instance, putting a radioactive particle like lutetium-177 linked to something that seeks out PSMA to create a new treatment, which has just been FDA approved this year for advanced prostate cancer and represents a real breakthrough.
Are there any other new targets in prostate cancer beyond PSMA and what you just described?
Absolutely. That's one of the things we're working on at City of Hope in conjunction with UCLA. Prostate cancer has this unique capacity to de-differentiate. So it can go from an adenocarcinoma to a neuroendocrine prostate cancer, in which case proteins like PSMA can be lost and new proteins can be expressed. So one of the reasons some of our treatments can fail is that if we're trying to treat the traditional or adeno component of the prostate cancer and it's in the process of transforming, then we're going to be missing treating that part of the cancer. So there are some targets that are seeking to treat neuroendocrine, like DLL3. And then also at City of Hope, we've worked on prostate stem cell antigen, PSCA, and have been trying to attack this using a CAR T construct, chimeric antigen receptor T cell.
Can you tell us a bit more about that therapy, CAR T-cell therapy?
So in leukemia lymphoma, CAR T cells have been strikingly effective. I mean, they cure patients where everything else has failed, including bone marrow transplant. In solid tumors, we are working hard to translate that, but finding the right target is just the first part of the equation. We also have to figure out dosing and whether there are some adjunctive strategies either before or after the CAR T cell goes in to heat up the tumor microenvironment and allow those T cells to get in and do their work. But importantly and really encouragingly, within the first handful of patients we've treated, whether it's with our own PSCA-targeted CAR T that we make at City of Hope or with some of the pharmaceutical company CAR T cells that target other antigens like PSMA, we have seen big responses where PSA drops all the way down and radiographic disease is eliminated or markedly improved. So we can see that these work, and it's just going to take some further effort going back to the bench and back to the bedside to make it work for more people, make the remissions nice and durable, that sort of thing.
What kind of a cancer patient, prostate cancer patient, should be considered for the CAR T-cell therapy? prostate cancer can be extremely slow moving, and maybe people will die of natural causes even though they've been diagnosed because of the time that it takes to implement some therapies.
You're absolutely right. Most of my patients don't need CAR T-cell therapy, thankfully. The existing treatments like surgery or radiation or hormone therapy can absolutely either cure them or manage their disease for long enough that they'll never need such an aggressive or intensive treatment.
Mm-hmm.
And it's interesting, it can still be hard to pick out who are those patients and who are the ones where it's going to take a turn for the more aggressive phenotype and really become more life-threatening. But we're really only studying CAR T-cells in the patients where they've not exhausted, but they've gone through most of the life-prolonging therapies, and they're running short on options. Nice to have some options in their back pocket so that we can get things organized, because CAR T-cells, you can't just sign on and get it tomorrow. It takes some manufacturing time and some lead time. Mm-hmm. So it's good if there's a treatment that they can still be using to control the cancer while they're getting screened and signed on to the CAR T-cell therapy. But it's really for advanced disease that has become resistant to traditional treatments.
When it comes to some recent clinical trials, trials are running all the time in the fight against prostate cancer. What, in your opinion, or what you've heard, are some of the most promising drug therapies that are on the horizon? What's the scientific community talking about the most?
Of course, I'm a little bit biased about immunotherapy. Mm-hmm. I've always felt that that's the way we're going to get these deep, durable remissions. So in addition to CAR T-cells, there's bispecific antibodies, bispecific T-cell engagers. So we're doing some work with some of those. But aside from immunotherapy, as I mentioned earlier, the radioactive particle linked to the PSMA antigen-seeking, this radiopharmaceutical is a new frontier as well. And so people are working on tweaking that. So for instance, we have a clinical trial with an actinium-225 particle linked to a KLK2, which is a different prostate cancer protein. So, once you see a success, then you want to work on optimizing other aspects of that platform. So a lot of people feel like actinium-225 will be a really good particle, has different characteristics than the lutetium. So we have immunotherapy, we have radiopharmaceuticals, and honestly, even going back to working against the androgen receptor, which is the big driver of prostate cancer, we have these new degraders on the horizon that are really, really promising. They seem to be able to overcome a common mechanism of resistance, which is mutations in the androgen receptor that lead to inactivity of our traditional and even next generation androgen receptor targeted agents. So I think those are another class of drugs to watch.
What should prostate cancer patients be asking their doctors so that they can basically, advocate for themselves and hopefully receive the most promising, the most appropriate treatment that's possible for their specific disease and circumstances?
First and foremost, I think every patient should feel empowered to ask for the complete sort of spectrum of options. Feel free to ask their questions, hear about the pros and the cons, and if they need a second opinion, there's never any reason to worry about hurting your doctor's feelings. I don't claim to have all the knowledge in the world, and I'm completely open to my patients talking to other doctors and hearing their perspectives, so that at the end of the day, you feel like you've gotten all the information you need to make the most appropriate decision. And then I would say clinical trials are something to ask about. Sometimes doctors don't think about them, especially in earlier stages of the disease, and yet sometimes there are really exciting clinical trials that can make big advances even in early stage disease. So in those types of clinical trials, you're not going to find placebos, but you're going to find tweaking, like personalization, using sophisticated molecular prognostication tools to maybe intensify or de-intensify therapy depending on whether a particular cancer seems to be more aggressive or less aggressive. So those kinds of clinical trials are happening even in early stage prostate cancer. So it's never wrong to take a moment and think about, well, is there a clinical trial that seems like a good option for me at this juncture. And your doctor may not know, so you may need to seek out additional sources. Sometimes prostate cancer support groups will have some information on that. Or, of course, feel free to reach out to us at City of Hope, and we're happy to try to let folks know which clinical trials are out there that they might be eligible for.
Well, give us a website where our listeners can reach out to City of Hope.
So it's www.cityofhope.org. And if you go to the prostate cancer landing page, you should be able to connect with my team in particular.
Dr. Dorff, I appreciate your time this morning. Thank you so much for joining us here on Health Professional Radio.
My pleasure.
You've been listening to Health Professional Radio. I'm your host, Neil Howard, in conversation with Dr. Tanya Dorff. Audio copies of this program are available at hpr.fm and healthprofessionalradio.com.au. You can also subscribe to the podcast on iTunes. Listen in, download at SoundCloud, and be sure and subscribe to our YouTube channel at youtube.com/Health Professional Radio.